It's a real pleasure to be with you this afternoon. My name's Sal Smith. I'm an expert by experience, and I currently work for Tees Wear Valley Foundation Trust. I see some of my colleagues on the call, so hello to you. My job role is trauma-informed care lead for the whole crisis pathway within Durham and Darlington. I've just started the role a couple of months ago. Rachel, would you like to introduce yourself before I make a start with the slides?
So, hi, I'm Rachel. I'm a mental health nurse, background in forensics, male psychiatric intensive care unit, and a crisis 136 place of safety. And I also have lived experience of sexual trauma.
Thanks, Rachel. So I was fortunate enough to be with many of you at the launch of the collaborative back last year, which seems a lifetime ago now, and we were allowed to kind of all be in a room together, and I wasn't permanently wearing pyjama bottoms. So it's a pleasure to join you again now for this workshop. We're going to be thinking about kind of having conversations on the ward around sexual safety, but really rooting that kind of in a trauma-informed care perspective. So I thought it might be useful to start today by thinking about what we mean by trauma and what we mean by trauma-informed care, and just sort of rooting ourselves in that. I'm kind of nervous and shy and awkward at presenting at the best of times, but found it's even worse online when I get to see my shy and awkward face right there in front of me. So I apologise now if some of this isn't quite as smooth as it might be. These slides that I'm about to share with you, I developed with a lady called Angie Sweeney. Angie's a survivor researcher and postdoctoral research fellow at King's College London, and she's written lots about survivor perspectives, about trauma-informed care, and about alternatives to biomedical psychiatry. She's fab. I would really kind of implore you all to go and check her out. It's a real honour to have worked with her on these slides and have the opportunity to share some of her thinking. So my starting point then is really what kind of we mean by trauma and what we mean by trauma-informed care. And maybe one of the challenges at the moment in the UK is that we haven't really got a shared understanding of either. I really love Beth Filson's work on this, and she describes trauma as something that happened to you that still haunts you today. And if it doesn't still haunt you, it sure did for a long time. And I love this definition because it focuses on the haunting, sort of the impact of the trauma, the impact it has on the person and the harm it causes, rather than seeking to categorise or quantify the event itself. And I think that's kind of the way that we need to head, the recognition that trauma can change you, change the way that you experience the world. So from that then, trauma-informed care is a whole system approach to delivering services that really recognises the prevalence and the impact of trauma. So we know some of the pilots, trauma-informed care projects that we've done into inpatient settings, up to 75% of people in that environment at any one time reported a significant trauma history. A recent systematic review by Moritz and colleagues estimated that half of all service users in secondary mental health have experienced physical abuse and a quarter have experienced sexual abuse. We know that this is not just a small group of our service users. Trauma and adversity is prevalent amongst the majority. So a trauma-informed care approach means an awareness of that commonness and pervasiveness of trauma in people's lives. And it means not disconnecting what we describe as people's symptoms, their experiences, from the context of what's happened to them. If we don't face the scale and impact of trauma, then nothing changes. So just to illustrate kind of why the need for trauma-informed care, the next couple of slides just illustrate some of the dilemmas and impossible choices that trauma survivors can face through contacts with the mental health system. And this is thinking broadly about the system, but I wonder if colleagues on the call kind of think about, in your ward environment, what are some of the impossible choices that trauma survivors might face. But some of the things that we've thought about is kind of accessing help. There's that risk of you be truthful and you risk unwanted treatment, or you keep quiet and continue without support. I think a good example of this is in kind of perinatal services, where women are really fearful about sharing what's going on for them because of the consequences in terms of social services. People have the choice of kind of using their known coping strategies, things like alcohol, self-harm, street drugs, and risk a real negative response from services and a quite judgmental one, or try to stop using those well-rehearsed coping strategies and stop coping. And then people are often faced with the dilemma of accepting psychiatric interventions or risking coercion and compulsion. And I know for me that tension around like come in informal or we'll section you, and that whole space there often left me feeling very powerless, and more so than just when I was detained. Next slide, please, Matt. If survivors go through the criminal justice system, their therapy notes can be used in evidence possibly against them. So because of this, some specialist services like rape crisis services won't see people until the criminal justice process has come to an end. So this can mean people can face an impossible choice between seeking criminal justice or receiving therapeutic support. And many specialist community services are under-resourced, meaning that survivors can face long waits for time-limited therapy. So people have that choice of opening up about their trauma, but knowing it's in a time-limited context, or kind of braving it and going it alone. So one of the fundamental principles of trauma-informed care, and a real good starting point, and I think relevant to our discussions today, is thinking about doing no harm. And yet we know from research nationally and locally that many service users do report harm and experience trauma at the hands of mental health services. And I guess some of the obvious sources of that, and things that, you know, systems have worked really hard to reduce, are things like sectioning, use of restraint, forced medication and seclusion. I think they're sort of more well understood, I guess, now that they can be re-traumatising for people, or indeed traumatic themselves. But some of the sort of less well-known sources, perhaps more covert and more insidious, are things that happen perhaps in the relationship between staff and service users, things like coercion, invalidation, people having lack of choice or voice in their care, diagnosis and labelling, kind of denying their story, and things like medication side effects. I know for me that whilst the restraint on a ward was quite traumatic, what was worse was kind of afterwards, that weird space where you were kind of expected to behave normally with staff as if that hadn't happened, and how that replicated kind of previous traumatic experiences. Next slide, please. So I just put this quote in because I think it really sums up some of this. So lots of expert by experience colleagues talk about the harm that's been caused by personality disorder diagnosis, and Sean Proctor say, I can't understand how the majority of perpetrators of sexual violence walk free in society, whilst people who struggle to survive its after effects are told they have disordered personalities. I think it's really useful. Hi Tony, I hope you can hear us okay. Welcome. So the failure to accept the reality of people's experiences, I think, connects to our collective and societal failure to accept the scale of violence, trauma and abuse experienced predominantly by women and children in society. And Stephen Coles said that to stand as witness to the extent and horror of people's accounts of pain and suffering is to encounter and experience fear, despair, loss and rage ourselves. So it's easier to avert our gaze, to turn away. And I think that's true right throughout kind of British culture, that sometimes it's too painful for us to really bear witness to people's truth, so we do turn away. But Paul Gilbert defines compassion as being able to do just that. It's our ability to face the brutal truth of people's experiences. This, he says, makes compassion a very different act from kindness. And if we can do that, if we can accept the reality of people's experiences, we can break the silence that often defines trauma and abuse, and we can start to change things. I really want you to hold that throughout today's session, because I think it's really fundamental to changing the way we understand safety in our inpatient settings. And doing this matters not only because it's the only way that we can begin to reduce the scale of violence in our society. It matters because relationships are not just the source of trauma, but they're the source of healing. So in trauma-informed services then, whatever the trauma looked like, you do the opposite. So Concetta Pero identified a number of oppositions, including moving from fear to safety, from control to empowerment, from abuse of power to accountability and transparency, and from darkness to creativity and joy. And I think those 4 oppositions and thinking about what people experience through sexual trauma and trying to move to the opposite in our environment, a place of healing, is really fundamental to this work. And through that, through organisational change, through embedding trauma-informed approaches, we offer opportunities to work with people differently and support healing, so survivors can feel listened to and believed, not denied and invalidated. Our responses can be normalised and accepted, not pathologised. Having people bear witness to our pain rather than feeling we must carry it alone, and being seen as strong and having survived rather than damaged or lacking in resilience, and being supported to move forwards, recognising our agency and expertise. So next slide, please, Matt. And if you just click again, I think there's some more text on that. So there's just another couple of quotes that I really like that sort of illustrate that point, that yes, lots of people who come into contact with us will have felt real harm in interpersonal relationships, but it's also those relationships that can be the source of healing. So next slide, please, Matt. So what does this mean for us thinking about developing sexual safety in the ward environment? I'm hoping some of the previous slides and thoughts around trauma-informed care might start to spark some ideas around some of the practical or process or environmental things that people might do to change that environment, especially paying attention to those oppositions. Some of the stuff that I was thinking about before today's call was thinking about having choice about same-sex accommodation, having options about restraint, PRN, so having those conversations about, you know, if people do have to put hands on what will be the least harmful, having clear shared understanding that's mutual between patients, visitors, staff about what is okay within our environments, thinking about physical health examinations, how people can feel more in control and safe during those, having groups of service users or carers come together to explore what sexual safety might look like on the ward, developing better relationships with specific services, having peer support workers to help some of those relationships. So they were just some of my ideas, but the focus of today's session is really starting to think about those initial conversations and how we can develop confidence in having those conversations as broader conversations around safety. And I think really paying attention to the relational element. So if we can grow the emphasis on using the relationship to increase safety, I believe really strongly that that'll reduce the need for other practices that we have to keep people safe on the ward. And doing that with an eye on attachment and an eye on trauma, kind of being aware that the relationships that we have with patients on the ward have the potential to either replicate abusive dynamics or help people heal from it. I know of one women's forensic unit, I think they're part of the pilot of the provider collaborative work, who've sought a family therapist to come and support staff to really think how they can build that relational security, relational safety, so that it can reduce other forms of keeping people safe. I think something to touch on here is thinking about staff attitudes towards some of the people on our units who have experienced sexual violence and who perhaps have ended up with a personality disorder label. Like, is it too much to expect that they're going to trust us and trust that we will believe them, given they might have been treated by the system? So I think one thing sorry Matt, just go back, just one thing that we might want to explore when we get into the more interactive bit is kind of thinking about what people are scared about in terms of opening up these conversations and building these relationships where we can talk about sexual safety. And some things I wondered about is kind of whether people's own experiences themselves of sexual violence makes it difficult, people's kind of own belief or sort of their comfort talking about sex and sexual relationships and sexual violence with the people on the ward, whether people feel embarrassed and not know how to bring that up, and then kind of fear about how to respond and the pressure to fix things or sort it out for the patient. And we can perhaps explore that a little bit later. So yeah, next slide, Matt, and I think this is the last one from me. So some of the things I thought about in terms of how we might start conversations, perhaps identifying opportunities to have them. So if having conversations around safety planning, crisis planning on the ward is part of your normal assessment process, is it possible to integrate kind of having a conversation around sexual safety within that? If you've got people who are well known to community teams who've already built some of those therapeutic relationships, perhaps with care coordinators, are there opportunities to work more collaboratively to think about a person's sexual safety with those teams? And again, always kind of bearing in mind those oppositions, and when you're having those conversations, how to create that sense that the person has control and is empowered to sort of make those decisions themselves. I wondered about kind of practicing together as a staff team, just how to bring sexual safety into the conversation, because it is, you know, it can be awkward, it can feel difficult if it's not something that's part of your normal repertoire of that interaction with somebody. It can take a bit of practice for that to feel comfortable. I think one thing to pay attention to is sometimes so much can be communicated with very little said. So, you know, Sal, we really want to help you feel safe whilst you're staying here on the ward with us. Do you have a sense of anything that could help? So I'm not going into sexual safety particularly, but you know, I might respond, yeah, I'd feel really uncomfortable with a man being on one-to-one obs. I'm telling you a lot there without having to go into the detail of my trauma history. I think sometimes these conversations don't have to be overwhelming and as frightening as we perhaps anticipate they might be. But I think it's really key to kind of respect the patient taking the lead on what they feel comfortable with, and again, thinking about them feeling in control of the conversation and that they can share as much or as little as they want to. I think one really good starting point for this sort of work is perhaps doing some staff training to increase knowledge around typical trauma responses relating to sexual abuse and sexual violence, and making sure that staff have a good understanding of things like flashbacks, dissociation, people's hypervigilance, and even people who are sort of hypersexual as a result of sexual trauma. I think that's something that's really misunderstood. And then lastly, I wondered kind of having an awareness of LGBTQ issues and whether this might help this piece of work, in that I think our tendency probably is that lots of our starting points come from a heteronormative position, and it's really important to consider the differences from people within that community. I've talked way longer than I think I was supposed to, so sorry. I'm going to pass over to Rachel now, but thank you for listening.